and social providers and commissioners. And I'm here today, as Kim has mentioned, to talk to you about the importance of using robust and nationally recognised standards, more specifically using NICE's work locally for successful measurement and improvement. I'm going to be describing the key features of NICE quality standards, and that most of you will already be aware of them. But just to explain the purpose of them, I'm explaining the purpose, hopefully, I'll be able to make you more aware of the potential for using them to drive quality improvement. All advice that I'm giving is based on something that's available on the NICE website called the Interpractice Guide. And that is a guide on how to use NICE quality standards, advice for providers and commissioners of health and social care. I worked with that with my colleague Jane Moore. You can get it via this URL. This is the short one. So www.nice.org.uk/interpractice guide. Or you can access it on the landing page of any piece of NICE guidance or quality standards. There's a link there to the Interpractice Guide. So all of what I'm about to say is covered in more detail in the Interpractice Guide. So what are NICE guides? What is NICE guidance and quality standards? How do they relate to each other? Should they be used in the same way? Hopefully I'm going to cover all of that now, but obviously any questions I'm more than happy to take at the end. NICE produces evidence-based guidance. The evidence that we use, it's not all randomized controlled trials. We use lots of different types of evidence, research studies, experimental and observational. We use quantitative and qualitative feedback, process evaluations, descriptions of experience, case studies. All sorts of evidence goes on to form guidance. Guidance is a set of systematically developed recommendations to guide decisions for a particular area of care or health issue. So to guide commissioning decisions, to guide treatment decisions, guide decisions about service configuration and service structure. So the guidance is for everybody really, to bring clarity to what the evidence tells us is effective. And then we have quality standards. NICE quality standard is a concise set of statements, usually about 6 to 8, and they're designed to drive and measure priority quality improvement. They are based on guidance, which is based on evidence. So looking at NICE quality standards, then you know that you're looking at a set of evidence-based quality standards. A bit too quick then. And here's where you'll find them. So this is a NICE website. The address is www.nice.org.uk. This is the homepage on the website, and you'll see that it says, "Welcome to the NICE website." We changed this about 6 weeks ago. So this presentation is also going to act as a bit of a guided tour of the NICE website, because I've taken lots of screenshots so I can show you where to find the things that I'm talking about. So in the top middle, you'll see highlighted standards and indicators. Click on that. That's the best place to find the list of all of the NICE quality standards. You can search for a topic in the search bar. So if you wanted to know if there's a quality standard on pneumonia, for example, type pneumonia in there, and the search results would include the quality standards. But if you want to browse the full list, and there's about 70 that have already been published so far, then click on this bit in the middle, standards and indicators. As an example of one, you'll see this is QS 68, so it's the 68th one that we published. We published it last month in September, and this covers acute coronary syndrome, including myocardial infarction. So it's a clinical topic. You see there are 6 statements, and they describe specific aspects of the acute coronary syndrome pathway, but they are prioritised areas for quality improvement. So they don't address step by step the ACS pathway. These are areas where quality improvement will have a high impact on safety, experience and outcomes. So they could be high impact, or they could be areas where quality improvement is necessary, because we know that practice currently differs from what the evidence tells us would be effective. Or it would be that we know that there's a lot of regional variation, and the way that we prioritise the areas for quality standards is Firstly, by stakeholder engagement, so we put out a call to key stakeholders and via the NICE website and anybody that's registered as a stakeholder for that topic. And we ask them to propose areas that are quality improvement. And of course, we also look at research and uptake data as well. If you click on the bottom left-hand side of the quality standard landing page, so this is the quality standing landing page, bottom left-hand side it says sources, and that will take you to a list of the guidance that the quality standard is based on. So you'll see here that the ACS quality standard, those 6 statements are based on 1, 2, 3, 4, 5, 6, 7 pieces of guidance. So the first thing I'll say is that a NICE quality standard is not another version of a NICE guideline. It's based on several pieces of guidance, often from sources other than NICE. So you'll see that we've got in here strategies from the Department of Health and Welsh Government as well. This is, for example, of a quality standard. It's on surgical site infection. This was published a year ago, last October. There's 7 statements, again highlighting priority areas for quality improvement. One thing I wanted to point out about this one is how very basic some of the statements are. The first statement, people having surgery are advised not to remove hair from the surgical site and are advised to have or help to have a shower, bath or bed bath the day before or on the day of surgery. So really quite basic. The quality standards they're not aspirational, they're not all aspirational. They might describe areas where there's work to do, and some of them will describe areas that are very aspirational for some organisations, whilst describing what currently happens in other organisations. I'm thinking about stroke. When we first consulted on stroke quality standard, access to CT scans covering London at the time, and for many organisations they felt that we were describing what was already happening. Now that I cover the East Midlands and the East of England, I think that's still aspirational, still a challenging standard for lots of layout really. So the statements aren't all aspirational, some of them are really quite basic, but they're all based on evidence. So those 7 statements are actually based on all of these guidelines and all of these as well. And you'll see that, again, they're not all NICE guidelines. Another feature of quality standards is that they're not all clinical topics. So we produce quality standards chair as well. A topic obviously crosses prevention, public health, so health promotion, clinical care, healthcare, social care. There would only be one quality standard for that topic, and we'd consider all of the aspects within the one quality standard. But this one is very specifically about supporting people to live well with dementia. The sorts of things in here include, statement 4, people with dementia are enabled with the involvement of their carers to take part in leisure activities during their day based on individual interest and choice. So very much about quality of life, very much about improving people's independence and well-being. But again, it's still based on reams of guidance. You'll see here all of these are from the Social Care Institute for Excellence, and we've got one from NICE, and that's the clinical guideline for dementia. So some of the quality statements based on guidance, which is based on evidence, and how can you use them to drive and measure priority quality improvements? The advice that we give, and obviously I don't know if you're from provider organisations or commissioners, so this is very generic advice really, is that an initial assessment is the first step for quality standards, and it would really need to be led by the people that are providing the service. So an initial assessment considering for each statement within the quality standard, is statement relevant to the organisation? If so, how does the service currently compare to the statement? So a narrative response really. The source of any information to evidence this, so what has informed that assessment, and I'm going to give you some examples of the source of information that can be used to evidence this. An initial assessment of what actions and resources would be required in order to improve the service so that it meets the quality standard statement. And an initial an initial assessment of the risk associated with not making these improvements. Now, all of that information can help to identify priority areas for quality improvement. It can help to prioritise those areas. So the sources of information to inform the initial assessment include baseline assessments and action plans for nice clinical guidelines. So if there are clinical guidelines related to the quality standards, organisations often use the assessment tools to undertake a gap analysis, if you will, to look at how the services compare to the recommendations. So there could already be some information in there about how the service currently compares. Any new or existing service user feedback. So it might be that you decide that you want to undertake a group or a service user questionnaire in order to answer some of the questions, or it might be you already have existing service user feedback or even complaints or serious untoward incidents that can help highlight how the service currently compares. Audit information, including national audit data, and we do highlight where national audit data measures any of the quality standard statements. I'll do that in a minute. It might be that you can't answer the question, you don't know the answer to the question, and you need to talk to your audit colleagues to get some advice on how you could undertake an audit if that's the preferred method to answer a question. Having activity data to answer the question. So the team really shouldn't be undersold. You know, we want an initial assessment at the moment of how the service compares, and this can be cross-checked against outcome data at a later date if necessary, but this is just initial assessment. Process maps can help plot the service from a start point to an end point and can help articulate the team's views on how the service compares, and again, user experience interviews. So I mentioned questionnaires and focus groups, but if you've got any existing user experience interviews, or if you'd like to undertake them, then the quality standard statements can act as a useful spine point for that. Once you've got your initial assessment, assessment can be used to provide assurance. So if the assessment suggests that the service is in line with the quality standard, then that can provide assurance to the organisation's board and to commissioners and to service users, and indeed it could be included in the trust quality account or organisation's quality profile if it's a social care provider. If the assessment highlights areas that require quality improvement, then it can help inform local quality improvement work and programme planning. So it can identify priority areas for quality improvement within a service area. It can support discussions with commissioners. So it's likely that the improvements will either be small things that need to be led by the provider. So thinking about the surgical site infection, the shaving one, probably not something that you'd need to discuss with your commissioners, probably not something that they're likely to include in a service specification or a sequin, something that you need to lead on as a provider, and the changes need to be dealt with internally, assured appropriately. If it's something that is going to require a lot of effort, so perhaps the IV fluid quality standard talks a lot about competency and skills. If it's going to take a lot of effort and potentially have a very big impact on outcomes, then it could be a good one for the sequin indicator. I'm going to show you the measures and how they can very easily lend themselves to sequin indicators. It could be that the gap requires whole system redesign. So thinking about the ACS quality standard that I put up at the beginning, there's a talk of reperfusion strategy and ensuring that people that have an ST elevated MI have access to reperfusion within 2 hours. Not something a provider can lead on their own. It needs to work across all sorts of organisational boundaries, including ambulance services and so on, and would need to be something led by perhaps a strategic clinical network or commissioner. But very much need to be discussed with the commissioners and how it's going to be prioritised locally. It can inform the organisation's annual audit programme. So if it's identified areas where you quite simply don't know the answer, you don't know how the service compares to the quality standard, then I'd suggest that's probably a priority area for audit. And it can inform local risk management because it's highlighting areas where quality improvement is required, and it can help identify areas where SUIs could happen or complaints could result, but you're identifying them proactively. Okay, this is an example. All of the case studies, and I've included 3 in the presentation, are available on the NICE website, the shared learning database, and they're also available via the Interpractice Guide. But this organisation followed this process. They wanted a robust method for using NICE quality standards. They saw staff are aware of them, and they identify a clinical lead who completes the review of the statements, and they use existing evidence where available, for example, training records and environmental audits. Another example, in Scotland, the CCG and the council and the provider organisations are working together to take assessments, and then where indicated by the initial assessment, they set up small topic-specific task and finish groups to lead on the quality improvement work and monitoring to see whether or not the changes are actually resulting in improvement. So there's just a couple of examples of approaches to using quality standards. Okay, this is an example of a quality system of heart failure, and you'll see here, instead of clicking on the middle bit, quality standard, which is where the list of statements would be, I've highlighted overview and resources. You can access that page by clicking on that. Side, there's a link to resources, and I'd urge you to click on these links, so overview and resources, or resources on the left-hand side, on the quality standard or guideline landing page on the NICE website, because there's a wealth of resources available that help you to use the guidance or the quality standard, including something called support commissioners, if you can see that. And it actually says support for commissioners and others, and it covers a lot, including context and epidemiology, so prevalence rates and so on. Really useful for a provider if they need to think about a case for investment or putting together a business case. It covers resource implications, cost impact, so on. But I'd like to draw your attention to the last bullet point, as well as all of these sort of contextual types of information. And there are links to national drivers and other useful resources, including patient information, leaflets and so on. So very practical stuff to help with any quality improvement work. Behind each quality standard, behind each quality standard statement, also a list of other resources. We have the quality standard statement, quality measure, interpretation of what the quality statement means for each audience, definition, source guidance, and so on. So thinking about measurements, one of the things that I will say, I've worked in quality improvement for a long time and feel really passionately about it. I know how difficult it can be to agree a local measure that you can use to see whether or not the changes you make do actually result in improvement. And the quality standard committees that have produced each individual standard have worked very carefully to come up with measures that you can use to see whether or not changes you make do result in improvement. And see here, this one is from the heart failure quality standard. It's talking about access to 2-week assessment and diagnosis. And the denominator, so the group of people that this measure applies to, are the number of people referred to specialist assessment, including ECHO, either because of suspected heart failure and previous MI, or because of suspected heart failure and high BNP test. So that's the group of people that this applies to. And then I've gone too far. And then the numerator is the number that did receive ECHO and an assessment within 2 weeks. So it's a detailed measure that you can use locally to see whether or not the changes that you make do result in improvement. Measures here also lend themselves really well to local sequin indicators. So if you are looking to improve access to ECHO, for example, in your local area, then they could be an excellent sequin indicator. We'll include interpretations of what the quality statement means for each audience, which can be incredibly helpful if you're undertaking a service review. So, for example, this one, service providers ensure systems are in place for people with suspected heart failure and previous MI or suspected heart failure, etc. Very easily turned into a question for a peer review or a local service review. How do we ensure, or what systems do we have in place to ensure that people with suspected heart failure have access to ECHO and so on? Likewise, if a commissioner is looking to redesign a local pathway or working with providers to do that, then a good way of thinking that the pathway is going to be effective and deliver the desired outcomes is to check the pathway against the quality standards. So does this commissioned pathway ensure that people have access to specialist assessment, including an ECHO, within 2 weeks of referral? The study of an organisation having used the quality standards in just this way, and again it's available in the Interpractice Guide. They've been using quality standards in Greater Manchester to support their sector-led improvement work by using them for self-assessment peer review. This is a quick of the Interpractice Guide. You'll see the headings include assessing services against NICE guidance for quality standards, prioritise quality improvement, supporting changes in services not currently in line with NICE guidance, measuring quality improvement, and so on. As I said, the whole presentation I've just given is based on this advice, and you can access it from any quality standard landing page or via the short URL that I gave at the start of the presentation. But now it's over to you, really. I'm happy to take any questions. I can see I've run a couple of minutes over, but...
Thanks, Deborah. That's great. No, that's fine. We do have a few questions for you. I've got one from Sarah Coombs. She says, on quality standards say that clinicians should consider an approach. How should this be evidenced or reviewed when looking to see if a trust is compliant?
Quality standards say that clinicians should consider an approach. I'm familiar with that often coming up in guidelines, in guideline recommendations that we should consider doing something. And very much because NICE guidelines don't place clinical judgment. So it's an option that is on evidence that can be effective and deliver the best outcomes for individuals, but it needs to be considered in conjunction with the patient's comorbidities, any other drugs that they're on, the appropriateness really for that individual patient. So that's when we tend to say consider, when it didn't suggest that it is effective and safe and that it delivers the outcomes, but that it's one of a number of options.
Great. I've also got another one here. If a standard covers acute and social care, should the audit include those settings, or should the audit be limited to one setting?
If a standard covers acute, so an individual standard could potentially apply to acute and social care, then the acute should be looking at how their contribution to service compares to the quality standard statement, and the social care provider should be looking at how their contribution compares to the quality standard statement. The commissioner of the pathway or commissioners of the pathway should be interested in looking at the overall offer, if you will. So they should be looking at how those providers that they commission from are working towards achieving the quality standard statement. So commissioners would look at both acute and social care, but the individual organisation should only be looking at their bit. An acute trust couldn't audit a social care organisation's contribution, really. They'd just be looking at their own bit.
I've also got another one here. What are the barriers for trust to meet these standards, and then how does that equal to your challenges that you face? Do you often find that there's a barrier, there's a particular standard that a lot of organisations can't meet?
Barriers really vary, and that's why we used to talk about quality standards being aspirational, and a quality standard statement can be aspirational for one organisation and not for another. So how aspirational a quality standard statement is depends on the situation in an organisation. Likewise, to what extent is it a priority? It depends on the local situation. So how big the gap is between the current service provision and what the evidence tells us is effective. How big is the gap between the service and the quality standard statement? They're things that highlight how aspirational it is, how challenging it is, how much of a priority it is. But the barriers can really differ. It could be health economy wide. I mentioned access to CT scans in very rural areas. It can be really challenging, whilst elsewhere in the cities, it's the priority to maintain it, but it might not be challenging now. It could be a cultural barrier. So the surgical site infection, the shaving one is a classic, where culturally there's always been differing views as to whether or not a site should be shaved prior to operation, and there's a real shift in culture required. It could be about investment, training. The IV fluids one states clearly that people that administer IV fluids should be competent and trained to do so. That's of people. How do you put in place a governance structure to ensure that those people have completed the necessary training? So different barriers that are based very much on the local situation, local service configuration, local demographics, and that's the individual providers need to undertake an initial assessment so they can highlight what their local is and what the potential barriers are to implementation.
That's so interesting, like the shaving one. I've got one more question, and I think that we'll have to wrap up after that. Another one from Sarah, who says, often quality standards say that clinicians should... I just said that one. Sorry, it's from Sam. Are commissioners involved in developing the standards?
They are. We used it, sorry, I'm just writing down the question because I'm so used to doing that and I really need to do it well. Okay, they are involved. We used to pull together a quality standard group for each individual topic, and would include people who use, provide, commission those services. But because we're producing so many quality standards, we now have quality standards. We have sort of standing committees, quality standard advisory committees, and they lead on producing a number of quality standards with expert input. So we invite additional experts, topic experts, to help produce the quality standards. But there is a standing committee which includes commissioners, providers, clinicians, social care professionals, service users, people from charitable organisations and so on. So commissioners are absolutely involved in it, and we're also work very closely with NHS England to identify opportunities for using quality standards in national sequins, for example, in any national service specs. There's been some trials of those. So yes, we certainly do work alongside commissioners.
I'm really pleased to hear service user involvement as well. Yeah. Deborah, that's all we have time for, I'm afraid, so thank you very, very much. I hope you're able to join us on Twitter this evening in case there's any follow-up questions. For everybody, we're going to be signed to our #ClinicalAudit Twitter tag from 6:30 till 7 this evening. And we're also going to be having our TIC this afternoon from 4 till 6. Please also join us tomorrow for our third webinar session, which is going to be about stage 2 of clinical audit cycle, with Lila from NICE as well, and we're looking at the measuring performance stage of the cycle. I hope everyone enjoyed it today and you're all able to hear and IT worked well, and we look forward to seeing you tomorrow. Thank you. Bye.